So thanks for the invitation to speak. I'm going to go first, then Maureen. I'm just going to set the scene first. And we're going to argue that, in fact, that these long-acting drugs are not going to solve the problems of adherence and persistence. In fact, we argue strongly that they're not going to solve any problems whatsoever in PrEP, and that we need to be focusing on the problems with PrEP. These are my various disclosures. So firstly, it's very important that we agree on a couple of things, that we are not disagreeing with the previous speakers. We strongly agree that PrEP works. If you swallow the tablets and in future, hopefully you take these injections, PrEP stops the transmission of HIV. And it's really important that people understand this. We're not arguing against PrEP as a scientific intervention. We also know that for some people, maybe the majority of people, injectable PrEP is going to be better for them than oral PrEP. That's a great introduction as an option. And that we also strongly agree that PrEP should be used for everybody who needs it. So look at this map, which thanks to AVAC, the amazing people who put this together and update it every 2 or 3 months, you can see that PrEP, in terms of concentration, is very, very highly concentrated in the United States, with a few lucky African countries getting it. But these are absolute numbers. It's not percentage of coverage. And if you think about it, those are tens, hundreds of thousands of people getting PrEP at the moment. It's not concentrated where the epidemic is. It's not concentrated there in Southern Africa in terms of the numbers. And in fact, PrEP is not really being distributed anywhere in the world in any numbers outside of major cities. And it's also important to get your head around this. There should be many more people on PrEP than on antiretroviral therapy. You know, that we want people to be protected from getting the HIV, which means that, you know, there should be far more, in the same way with contraception. You want far more people to be on contraceptives than people are pregnant. This is a map of the number of people in antiretrovirals. You can see this is data from 2021. So we're talking about almost 30 million people on antiretrovirals, tens of millions of people on antiretrovirals. Now put that map next to PrEP, and you can see how badly PrEP is doing. PrEP is a failure as an intervention across the globe. And outside of a few lucky key population programs, very, very lucky key population programs, and outside of some tiny, of some cities like Seattle and San Francisco and London and Paris, PrEP is a complete failure as an intervention. Where in treatment, we're talking about tens of millions of people on antiretrovirals. We're talking about tens of thousands and sometimes just tens of people on antiretroviral therapy. And it's important to think about this. Now, people will tell me that, oh no, PrEP hasn't been around for a long time. Well, just remember that PrEP is very safe. All the studies show it's very acceptable to people. It's completely accepted by policymakers and governments around the globe, particularly in high prevalence areas. And it's been around for 7 to 8 years now. And yet it's being used by almost no one. When we had antiretrovirals around for 7 or 8 years, we're hitting coverage rates of 50 or 60%, and we were complaining that it was not fast enough. With PrEP, we're barely at 1%, and it's really important for us to start thinking hard about why that is. So we must stop talking about PrEP as if it's suddenly magically being in the mouths or in the arms of people around the globe. And we also have very little idea of who has cycled out of PrEP. The vast majority of people who've gone to PrEP, we know, have disappeared off these programs, and we don't know why. South Africa, that's not because people are not working hard on this. There are really, really good people who are working hard on this. Has only started around 100, probably close to 200,000 people on PrEP since the very beginning. A country which has around 67 million people on antiretroviral therapy has put only a tiny percentage of the people who are eligible for PrEP on therapy. So I'm going to argue that these new technologies are a distraction rather than facilitating access to PrEP. Even if we had 100% effective, 100% safe injection, it would do nothing for the epidemic because people just wouldn't get it. We've got to work out what is wrong with PrEP, and we've got to fix the health system that is not delivering the system at the moment, and fix the social support system that is not helping people get the access to what they need. And what we need is a radical rethink of PrEP delivery systems rather than focusing on these amazing technologies that nobody's ever going to see the light of day unless we fix the people who are actually handing them out. And I'm arguing strongly that techie solutions won't solve the underlying problem, and that while cabotegravir is very exciting, it's really irrelevant in the broader problems around PrEP. Over to you, Maureen.
Thank you so much, Dr. Venter. And I think I just wanted to start by saying that thanks to advancements in clinical research, we are now seeing more breakthroughs in HIV prevention research. I think for each passing decade, we are now making huge leaps, right, in terms of what we can offer individuals to prevent themselves from getting infected with HIV. And the good thing is that this is happening at a time when we know that more new HIV prevention tools are needed to address the heterogeneous needs of the different populations that are at risk of infection. I would also like to acknowledge and appreciate the efforts that are being made by researchers to engage communities during implementation of research. Even though I would still say that more engagement during the design phase or protocol development is still wanting. And we know that involving communities, like during the design phase of any clinical trial, is one way of making sure that the social, structural, economic needs of the targeted beneficiaries are taken into consideration when designing these new products. And I'll talk about why these are important. Just to agree with Dr. Venter, indeed PrEP works, right? It's highly effective in preventing new HIV infections, there's no doubt about it. But we know that PrEP adherence and persistence have emerged as major concerns as countries begin to roll out and scale up PrEP among different populations. But as we begin to think deeply about how we can address the issue of adherence and persistence, it's important for us, to note that, without addressing challenges, underlying challenges to access, these new breakthroughs will mean nothing. It's important for us to take a pause and ask ourselves how many people are accessing these new tests. To date, we still haven't met the UNAIDS 2020 targets of 3 million new PrEP initiations, right? And this is start 2022. So moving forward, addressing these bottlenecks will be very key. There are so many factors that contribute, to PrEP adherence and persistence, just other than just the delivery method, itself, be it long-acting or short-acting. First of all, if you're not going to invest in community education to address the community fears, issues around perceptions of risk, negative beliefs about the medications, or fears about, potential side effects, even with long-acting prevention tools, will not be able to address the issues of persistence and adherence. If we continue to ignore the social factors such as stigma, low decision-making power, especially among women, structural barriers such as policies that limit access for certain groups, issues of cost, will not be able to, will continue to sing this song of persistence and adherence. If the healthcare settings, where we'll be delivering these new tools remain unfriendly to key and vulnerable populations whom we know that need these new tools more, then we won't be able to address the issues of persistence and adherence. If the delivery channels remain medicalized and if we continue to lead more towards facility-based delivery models and not thinking of reaching people with services where they are, then we'll continue to have these challenges. And if our supply chain systems, right, continue to be fragile and to lack the agility they need to ensure uninterrupted access, to these services, then we won't be able to address the issue of adherence and persistence. If the HIV testing requirements for PrEP programs remain daunting and complicated for PrEP beneficiaries, then no one is going to access these services. So I guess the point that I'm trying to make is that, yes, indeed, long-acting cabotegravir is an amazing breakthrough, but on its own, without addressing these factors that I've highlighted, we won't be able to achieve adherence and persistence. Thank you so much.